What the evidence suggests, say in our field, is that by using the right type of contact lenses, or the right design contact lenses, we can reduce how myopic a child will be. So from a practical point of view, what that means is that practitioners should be aware of that and be prepared to prescribe soft contact lenses of these designs to children who they might have considered just for spectacles only, or there are a lot of children, especially in Australia, who are prescribed contact lenses for various reasons. Instead of prescribing standard contact lenses, practitioners should consider lenses that actually do have some efficacy in reducing how short-sighted kids become. What needs to be remembered with these clinical trials is that the value of 40% is an average. An average, if you ask anybody who knows averages, some will be above, some will be below. So what we would expect is not everybody to get 40%. We would expect some to have a much higher percentage, while others would not be nearly that high. Overall, the rate of progression will be less. We know that myopic progression tends to be greatest at a younger age, and it tends to slow down with age naturally. We would expect, if we're treating someone, if we're say got a young child, if we can get their rate of progression down to about a quarter to half a diopter per year, that is a good result, and we would expect an even lower result in an older population. If we start getting more than about 0.75, then we should consider instituting further treatment. One big way to reduce MK or microbial keratitis is to stop overnight wear of contact lens, and generally speaking, myopia control management doesn't involve wearing soft contact lenses overnight. Orthokeratology obviously wears the lens overnight, but if we maintain, say, a single use regime where you wear the lens once then toss it out, that way we don't need a contact lens case, which has also been implicated with microbial keratitis. We avoid overnight wear, and we institute the usual good practice of washing hands before and after you take out contact lenses, and obviously make sure that people only wear their contact lenses once, that they don't reuse them. What we find is the child will generally report a better quality of vision when looking far away. Now that, if we measure their vision, we won't find any difference. So if we got kids to read a letter chart, the standard letter chart, we wouldn't find any difference at all between multifocal lenses for myopic control or single vision lenses. But as soon as we ask them questions about how good is your vision, we generally do find a slight decrease for far away or distance viewing. But for both, when we ask them and when we measure it, we find absolutely no difference for anything closer than about 70 centimetres. There is a minimum pupil size that is needed before these lenses become effective in, say, older people, and once you get smaller than that, you do lose a lot of effectivity. In children, the pupil sizes are generally bigger, so there shouldn't be an issue with not having a big enough pupil size. The opposite can happen if your pupil is too big in contact lenses, that you can actually get a whole lot of unwanted optical effects